Is it really hard to be away?
I play classical music for it. I'm just coming back. It's so cute.
Okay, we're going to finish all the neurotransmitters today. Ask as many questions you want. I won't always know all the answers because a lot of times you guys are interested in drugs and disorders that I haven't researched. But I do want to show you a picture that I wanted to show you last time. This is red tide. In what context did we talk about red tide last time?
Toxic.
Yeah, it's a neurotoxin produced by the single-celled organisms. And what? No, they're not bacteria, they're protozoans. But it's produced in like a certain environmental conditions. Do you guys remember where the red tide bloom has been recently?
Florida.
Yeah, in Florida, in the Gulf Coast of Florida. And then here's our little friend just sitting there looking cute, not like he'd actually kill you. What was this one in relationship to? Yeah, it's pufferfish that produces a neurotoxin that causes conscious respiratory arrest. Yeah, because it blocks your acetylcholine receptors on your diaphragm. So, and despite the fact that he's just adorable, when he's pissed, you would not want to eat them, but humans do. Right? Because we're crazy. We're bored. It's boring. Adulthood is boring. What? No, when they puff up, it's just like a behavioral don't eat me. But they produce the toxin all the time.
When they puff up?
No, they produce the toxin all the time. It's a gland that they have that makes, for instance, whatever bigger fish want to that wants to eat them regret it, perhaps even with death. And that's also because their warning coloration. You can see the sort of black-white warning coloration. And then the last thing is just to show you the difference between a healthy brain and an advanced Alzheimer's brain. Now, this is very advanced because it's postmortem, right? Like as advanced as you can get. With Alzheimer's, do you remember what neurotransmitter is related to Alzheimer's? Yeah, it's acetylcholine. Acetylcholine is related to Alzheimer's. And it starts out with a decrease in acetylcholine in a certain region of their brain, but eventually you actually start losing cerebral cortex. And the size of the brain decreases with massively advanced Alzheimer's. And of course, at this point, the changes are irreversible. Okay, so remember what we are doing today is we are doing a tour of the neurotransmitters, right? Okay. And so the first category of neurotransmitters that we did last time was the choline derivatives, right? You guys remember our friends, the choline derivatives? So just remind me what kinds of things you need to know about each neurotransmitter category. So questions for you as we're going through this one. You're going to have a quiz on Wednesday. So listen to the questions that I'm asking because I'm trying to guide you in how to organize this information. Okay.
Thursday.
What?
Thursday.
Sorry, Thursday, yes. So do you remember what choline is? It is a water-soluble B vitamin, and all you do is take acetic acid and slap it onto choline. Okay, so the only neurotransmitter that you need to learn from the choline derivatives is acetylcholine. There are more. Remember that for most neurotransmitters, not all of them, because I don't make you learn the ones that are just like a little bitty neurotransmitter that's not particularly common. You need to learn the terminology. What word do you use to quickly say releases, responds to, binds to, whatever, acetylcholine? What's that word?
Cholinergic.
Yeah, cholinergic. Okay. And receptors, right? Often, not always. If it's not in your notes, don't worry about it. You need to know the receptors. And the receptors are all cholinergic, but there is nicotinic, cholinergic, and muscarinic, cholinergic. And you need to know whether it's CNS or PNS. Do you remember? This one's both. Okay. And then last but not least, drugs and diseases. Okay. You won't know all of this for every neurotransmitter category, but for the ones you're going to run into a lot, I gave you more information. Okay. Do you remember what drugs and diseases are related to acetylcholine? Alzheimer's and? And nicotine. Yes, Alzheimer's and nicotine. That makes sense? Okay. All right. So that's the first category, and we're going to use that as sort of like a template for what we learn about the other categories. Good? Okay. So let's do the next one. The next category are called biogenic amines. I want to explain to you what that term means because it's not particularly meaningful at first. Okay. So listen to this. The biogenic amines are derived from amino acids. So look at this figure for me for just a second. You don't have to memorize the figure. But these are amino acids, phenylalanine and tyrosine. Okay? So in order to, for instance, make dopamine, I make small changes to this amino acid such that it couldn't be used as part of a protein anymore, but it's still almost the same size. Does that make sense? So dopamine, norepinephrine, and epinephrine are all just modified amino acids. That's all they are. Okay, so that's what a biogenic amine is. It's an amino acid that's changed just enough so that you couldn't use it as part of a protein, but it's still about the same size as an amino acid. Everybody good? And we will see that part of the reason that you need to know categories is you will see it's going to be clinically important to understand that because these three are so similar to one another, does it make sense to you that they might be able to use similar reuptake mechanisms? Yeah, because they're almost the same shape and size. Similar breakdown mechanisms. Sometimes you can use drugs that treat them simultaneously because they're so similar to one another. So that's part of the reason that I make you organize them into chemical categories so that you know when you see dopamine, norepinephrine, and epinephrine, they kind of go together, right? Can you find a receptor that binds to one and not the other? Of course, right? But a lot of times because they're so similar. All right, so with the biogenic amines, these are derived from amino acids, but they're changed just enough so that you couldn't use them as part of a protein. The first category is the catecholamines. And catecholamines are the ones we were just looking at. So look up here for just a second. Realize I will never, ever, ever make you draw organic molecules in this class, but I do want to reinforce the similarity in the structure. These are all derived from an amino acid called tyrosine. Okay? And these three, dopamine, norepinephrine, and epinephrine, are collectively considered the catecholamines. So it's derived from tyrosine. And norepinephrine, and epinephrine, and dopamine. Okay. These two, we already learned because, of course, we learned them as hormones. We also learned this one as a hormone. But listen up. Epinephrine is more commonly released about 4-to-1 as a hormone. Norepinephrine is more commonly released as a neurotransmitter, about 4-to-1. But generally speaking, they interact with the same categories of receptors. Okay? So you've already learned those. You just haven't sort of learned their CNS activity. You learned some of their PNS activity. Okay, so, and then dopamine, our friend, is going to be, dopamine to me is one of the most interesting neurotransmitters. And even though you may not know it, dopamine is one of your favorite neurotransmitters because it's one of the reasons you have favorite anythings. Okay, so dopamine, it's mostly CNS, and it's really important in two different functions. It is part of what we call the reward pathway in the brain. So think about this for just a second. Evolutionarily, when you, for instance, eat something that is really nutrient dense, like something fatty or sugary, right? You should probably reinforce that behavior, especially historically speaking. If we're talking about out on the African plain and you come into a fruit, right? You eat it. What happens is your brain tells you that was pleasurable. To me, when you release dopamine, here's what dopamine tells you. That was awesome. Do that again and frequently. Yes? That's the reward and reinforcement pathway. And you can see how evolutionarily that would be useful. And you also, of course, release dopamine when you have sex, right? That was awesome. Do that again and frequently. That's what dopamine really does. So I want to show you a little bit about dopamine, then we're going to talk about some drugs related to dopamine. Does it make sense to you conceptually, sense that drugs that tap into the dopamine pathway are going to have two things that are characteristic of them? They tend to be pretty pleasurable, yes, and they tend to cause reinforcement and lead to addiction. Does that make sense to you? Yes? Okay, so let me show you your sort of dopamine pathway. It's also related to the serotonin pathway. This picture is more complicated than most of you guys want to go, but I know a lot of you guys have interest in addiction. So let me tell you a little bit about the whole dopamine addiction pathway. Basically, there's three important parts to the dopamine addiction pathway. This is the VTA, the ventral tegmental area. This is the nucleus accumbens. These two are habit formation and reinforcement. When you, for instance, have sex, these are both going to release dopamine, right? Okay. Now, in addition, what dopamine also does is it has axons that project to the prefrontal cortex, and this ends up being really, really important in addiction. Because what they do is they project to the prefrontal cortex and they inhibit prefrontal cortex activity. So I want you to think about this. So if you've taken a drug, right, that releases dopamine, then you like it, right? What it also does, especially over time with repeated use and repeatedly using that pathway, you reinforce the pathway and you inhibit prefrontal cortex activity. What does the prefrontal cortex have to do with sort of habit formation and behavior regulation? Any idea?
Higher level, like decision making and like
Higher level decision making. So this is really important, and they've only known this for about 10 years. What taking drugs that repeatedly activate this pathway do is inhibit your prefrontal cortex inhibition of behaviors, yes, that are good for the short term and really bad for the long term, yes? So you end up diminishing the sort of decision-making long-term implication portion of your brain with repeated activation of the dopamine pathway with dopaminergic drugs. Does that make sense to you? So it ends up being really important. And of course, the more you use a pathway, the more synaptic activity you get in that pathway, the more synapses you form because of neuroplasticity. Okay, so this is the whole dopamine pathway. Let's talk a little bit more about what dopamine does, and then we'll talk about some clinical implications. So it is used for motivation, reward, and reinforcement, food, sex, and some drugs, not all drugs. There's also a different portion of the dopamine pathway right here that notice doesn't project forward. Do you see this? The substantia nigra right back there. Substantia nigra is involved in voluntary initiation of motor activity. It's not the same one that's reward and reinforcement. It's a different use of the dopamine pathway. And this one ends up being clinically important because when you, for instance, have Parkinson's disease, that portion stops being able to produce adequate levels of dopamine, and you lose your capacity to control voluntary movement. Does that make sense to you guys? Okay, so the dopamine receptors are called D1 and D2. There's also some other receptors, mu, kappa, and alpha. We will see as we go a little further and talk about addiction a little bit more that one of the receptors that is used for dopamine called mu1 is the one that is really, really implicated in reward and reinforcement and addiction. So I want to tell you guys something and encourage you to sort of just be literate and read and think critically about this kind of stuff. So the clinical connection, of course, is addiction. And we know that we can see addiction sort of running in families, right? There's probably some genetic component to addiction that we don't completely understand yet. My own family is a great example, a terrible example of addiction. Both of my parents were addicts and my brother is an addict. I'm the only one in the family who hasn't had addiction problems. What could it be? Well, this is preliminary research, but it's kind of interesting. They think that perhaps the dopamine receptors, the type, category, affinity of your dopamine receptors for dopamine, and sort of the genetic predisposition that you have to D1, D2, mu, kappa, and alpha may predispose you to addiction or not addiction based on even with the same behaviors. So this is a research article that you may actually find interesting. It's a comprehensive review, and you can get the entire PDF of it if you were interested in reading it. This one was in 2009. There's been research from here, but since it's a review article, it's a good sort of beginning to end. So what may predispose, for instance, me and not Mike to addiction based on, let's say, prescription use of opioids, right? Why might I need to be more careful about that? Well, perhaps I have different categories of dopamine receptors than he has, right? And what would be great is if we knew enough about this that, for instance, you could test your 14-year-old, right, before you chose what kind of drug treatment to use for even, a pain kind of thing. We're not at that point yet, but it's an interesting avenue that's being explored. Okay, so the clinical connection, of course, to dopamine, and we're going to come back to dopamine several times because other neurotransmitters, when a behavior uses a neurotransmitter, but you also want to reinforce it, will also have dopamine release. So for instance, opioids, that's its own category of neurotransmitter, but you release dopamine in the whole reinforcement pathway whenever you do that. So we'll come back to that as we go back to this. Okay, so the clinical connections with dopamines is addiction, of course, Parkinson's disease, right, with the substantia nigra, and then you may or may not know that schizophrenia is actually caused by an excessive release of dopamine in parts of the cerebral cortex, and that's genetically inherited as well. You can't actually say that addiction is genetically inherited, but a predisposition to addiction is genetically inherited, but dopamine has a very strong genetic inheritance pattern. Okay, so let me show you your favorite neurotransmitters. So your favorite neurotransmitters, whether you know it or not, are these three: dopamine, serotonin, and norepinephrine. The middle of this Venn diagram is the ideal place. I think I've maybe been there for 10 minutes in my entire life, right? When everything is the perfect amount. So for instance, if you have too much serotonin without the others, it can actually manifest as obsession and compulsion. Dopamine, if you have too much dopamine without the others, you can have schizophrenic behavior, and norepinephrine can make you entirely too spazzy without its two balancing ones. So you can sort of see how these guys overlap. So we're going to come back to this several times because you will not be at all surprised that when you are trying to, for instance, treat depression or anxiety, or like anhedonia is like, I don't have any pleasure in life, then quite often what they do is they mess with these. One, two, or a combination of them. Sometimes you mess with all three simultaneously, and we'll talk about treating that stuff in just a minute. Okay, so let's go to norepinephrine, and then we'll come back to that. Okay, so norepinephrine and epinephrine. Norepinephrine is mostly CNS. Epinephrine is CNS and PNS. It, of course, also serves as a hormone that we've already learned called adrenaline. And so what does norepinephrine do? Norepinephrine is your up CNS neurotransmitter. It's your like, I'm awake, I'm paying attention, alertness, concentration, and energy. That's what that one is. It's also a PNS neurotransmitter involved in fight or flight, right? Okay, epi, norepi. Okay, so let's just talk a little bit about the history of this for just a second. So dopamine has D1 and D2 receptors. The terminology related to dopamine is dopaminergic. And then we've got drugs and diseases. So this one, actually, the terminology can be a little confusing, so pay attention. So we don't call these epinephrine and norepinephrine. What they call them collectively is adrenergic, because I want you to think about the history of sort of how we found these chemicals. So these function as both hormones and neurotransmitters. Everybody with me on that? Hormones and neurotransmitters, yeah? Okay. Which one's going to be easier to find, a hormone or a neurotransmitter? Hormone, because they circulate in the bloodstream. So when they found these chemicals, they originally found them in the bloodstream and traced them back to where? The adrenal gland, exactly. And they labeled everything related to them, all the receptors and all the everything, adrenergic, right? And then when they found them in the brain, they didn't change the name of everything because it's the same freaking receptor, right? It's just not coming from the adrenal gland. So this is a little bit of an anachronism, right? It's like was named before we actually knew that it was a CNS neurotransmitter. Everybody okay? So what adrenergic refers to is anything that binds to, releases, activates, whatever, norepinephrine and epinephrine. Okay, so that's the short way to say it. And we will see, and this is going to become important for the rest of the semester, that there are two different subcategories of adrenergic receptors, alpha and beta. Have you guys ever heard of beta blockers? Have you ever heard of a beta blocker? A beta blocker blocks the activity of epinephrine on beta adrenergic receptors, and it works on the heart. And so you can use beta blockers to decrease heart rate and drop your blood pressure. And so we're going to run into beta adrenergic receptors when we get to the cardiovascular system, the PNS activity. Okay, so norepinephrine is this guy right here, alertness, concentration, and energy. And then dopamine is this guy right here. So let's talk just briefly about catecholamines. And then we're going to go back to clinical applications and talk about Wellbutrin and how that one works, okay? So catecholamine removal. So you guys remember that there were basically 4 ways to get neurotransmitters out of the synapse. Do you remember what they were? What are the 4 ways to get neurotransmitters out of the synapse or remove them from the synapse? Enzyme, yeah. This is this guy, right? What else? Reuptake, yes. 2 more. Diffuse away. And then what was the ball boy? Astrocyte. Okay, the only 2 that I know that we've ever treated clinically are the enzymes and the reuptake mechanisms. The other 2 we don't really mess with in any way that I know. Okay, so does it surprise you that because these chemicals are so very similar, you can use, they actually use similar reuptake mechanisms and similar enzymes to break them down, right? Which means, of course, that you can use drugs, yes, that will treat both of them at the same time, or all 3 of them at the same time, really. Does that make sense? Okay, so let's say that you had depression, and you went to your doctor and you had depression and you didn't have any energy. One of the ways that they could actually choose to treat that is with Wellbutrin. This is usually not the first tier. Usually they use SSRIs first, but we're going to do these first. So Wellbutrin, also called bupropion, which I can never pronounce, okay? Bupropion is a SDRI and SNRI. Selective dopamine reuptake inhibitor and selective norepinephrine reuptake inhibitor. Okay, so you guys have heard of Wellbutrin, right? Okay, you have? Okay, so Wellbutrin is a treatment for depression. And based on our figure that we looked at here, can you imagine that if you increased the apparent amount of dopamine and norepinephrine in the synapse, you could have a relief of certain types of depression? Does that make sense to you? So you would have more reward and motivation, right? You would also be slightly more up. Does that make sense? Okay. It's different than the serotonin. The serotonin regulation is mood regulation. It decreases the highs and decreases the lows, right? It just sort of flattens out your mood so that you can handle life a little better. But sometimes SSRIs don't work for people, or they don't like the side effects of SSRIs, so they choose to use an SD or an SNRI instead. Now, does it make sense to you that these, Wellbutrin, the SDRI and SNRI, are contraindicated for someone with anxiety, but could be used for someone with depression? Do you see that what you might not want to increase in someone with anxiety? Which one of these neurotransmitters might not be particularly helpful? Yeah, norepinephrine. So it's good for you to know. I would love for you guys to all be very, very educated patients and consumers of medications by the time you leave here, so that you know which questions to ask, right? So if you have anxiety, Wellbutrin is contraindicated, and as a matter of fact, it can cause panic attacks in someone who's dealing with anxiety or has a predisposition to panic attacks. It's much, much better for depression than it is for anxiety. Does it have symptoms? Well, everything neuroactive is going to have symptoms. Every single thing you can possibly imagine is going to have symptoms. So, of course, it can cause sleeplessness, right? Does that make sense? Okay. And sometimes it's better for getting you out of bed, but it's a little hard to calm down when you get onto the highs with Wellbutrin. So that's Wellbutrin, or bupropion. It's a norepinephrine and dopamine reuptake inhibitor. It's used as an antidepressant. And then there is another category, and this one is not used in the United States very often at all, although it's really effective, and it's kind of interesting. So this one actually works at different synapses. At other synapses, instead of reuptaking dopamine and norepinephrine, there's an enzyme called monoamine oxidase. Okay, just stick with me. The drug category that can treat depression is a monoamine oxidase inhibitor. So what it does is it blocks the enzyme. So again, norepinephrine and dopamine stay in the synapse longer. You with me? Okay. And it's really, really useful for treatment-resistant depression. So let's say you've tried every damn category of SSRI, right? and you've tried the SDRIs and the SNRIs, and you are still just depressed as hell, they could choose to use the MAOIs, which is a monoamine oxidase inhibitor. But one of the reasons they don't use these very often is that they have complications with so many foods and so many over-the-counter medications that getting people to be compliant so that they don't have these nasty interactions is really difficult. Nardil and Marplan are the two that I know of. They, for instance, you can't eat cheese. Like, how the hell are you supposed to live like that? I'm depressed just thinking about it. You can't drink red wine at all. I mean, I'm just going to call it a day. I know, exactly. And then there's a whole bunch of over-the-counter medications and plants that you can't have. So unless you guys know more about this, because I've tried to educate myself, it's a little difficult to get information on this in the United States. These are mostly used when people are inpatient because you can control what they are taking in, right? You can control the other things that they're taking in. When people are outpatient, even if this was very, very effective, it's really difficult for them to use it because the complications are pretty violent when you have them interact with drugs and other things. So that's Nardil and Marplan. So you probably won't be getting those as a medication. Go ahead.
How do those differ? How does that differ a lot from the SSRIs?
Okay, so they are monoamine oxidase inhibitors. They inhibit the enzyme that breaks down norepinephrine and epinephrine. And then the other category was the SDRIs that inhibit the reuptake, right? So for whatever reason, those guys actually have massive negative interactions, but the SDRIs and the SNRIs don't. Yeah, those don't cause the same kind of problems. So that's Nardil and Marplan. And as far as I know, and if you guys work in psych, will you ask somebody about them? Because I want to know, like, under what circumstances would they use those here? Anybody work in psych? No? You do? Oh, find out for me. Okay, cool. I know she will too. Okay, so there are other biogenic amines. Okay. So now we're done with the catecholamines. FYI, they're all together because they're all derived from the same amino acid called tyrosine. Okay, so now we are going to be into, it's still a biogenic amine, meaning it's still derived from amino acid and changed it just a little bit, but it's not in this category. And we're going to talk about our friend serotonin. Serotonin is not derived from tyrosine, it's derived from tryptophan, another amino acid. And it's, I don't know, have you guys learned the structures of amino acids, or do you do that in biochem? You haven't learned them? Okay, there's 20 amino acids. Eventually somebody's going to make you memorize all of them, but it's not going to be me. Okay, so I want to show you what that one looks like. Okay, so look at this picture for just a second. Not that you have to memorize it at all. Here's serotonin. Serotonin is also called 5-HT because it's 5-hydroxytryptophan, because only difference from tryptophan is this little hydroxyl group right there. Okay, so this is tryptophan, this is serotonin. Okay, all right, so 5-HT. Serotonin is a CNS neurotransmitter. I don't know that it's used in the PNS. I can't promise you that it's not, but I don't know that it isn't. It's important in the entire brain. Look at the different things that serotonin does, and you can imagine why it's really, really important to be a selective serotonin reuptake inhibitor instead of just a serotonin reuptake inhibitor, because it is used in the brainstem. It's usually inhibitory. It also regulates sleep. It regulates emotion. It regulates sensory function and motor function. It regulates hunger, mood, sex drive, anxiety, obsession, compulsion, and memory. So if you would like to, for instance, treat this or mood, right? You don't want to treat all this crap at the same time, right? You do not want to, for instance, start having hallucinations, lose your sex drive, massive changes in appetite. So what happens with serotonin is when you try to manipulate your serotonin, you want to be selective about it. So serotonin receptors are called either serotonin-ergic or 5-HT-ergic because 5-hydroxytryptophan. So let's talk about the things that you've already sort of known about serotonin and SSRIs. So let's look back at our picture right here. So here's our friend serotonin. When serotonin is released at normal levels, it usually manifests in you, for instance, not completely melting down when you have a flat, right? not completely getting outrageously anxious when your kids leave the front door open for the 16th time over the course of a day, right? So the little bumps that happen in life, serotonin helps you just weather the little bumps. When your serotonin is abnormally low, it can manifest as anxiety or manifest as depression. So one of the things that you can do in order to treat anxiety and depression is use an SSRI, a selective serotonin reuptake inhibitor, right? And you want it to be as selective as possible because you really do not want to hallucinate. You don't want to gain 35 pounds. You don't want to have no sex drive. So let's look at this. This is only to 2005, but I love the figure so much that we're going to use it anyway, and there are more since then. This is sort of the history, the timeline of SSRIs, selective serotonin reuptake inhibitors. Notice that the oldest one, right back here, is Prozac. And then number 2 right here is Zoloft. And then you start getting some new ones. These are all the disorders that it is approved for use for, right? So notice that you've got like one that's approved for use for a whole bunch of different things. Okay, so what happened over time is that we got the capacity to be more selective because we knew more about the receptors, right? So these are the least selective ones that you have way down there. What does that mean about the number of sort of unintended side effects when they're the least selective? Yeah, more side effects. And you guys probably know because you've either experienced it yourself or you know somebody who's experienced it. Do you know of any of the sort of unintended side effects of SSRI usage? Anybody have any idea? Yeah, you can have digestive problems, weight gain, low sex drive, yes, sleep disturbances, appetite disturbances. All of those things can happen with SSRIs, right? And so what happens is we started getting more selective as time moved on. But as you get more selective, they also don't seem to work on as large a population, right? So for instance, this guy right here, which is Paxil or Lexapro over here, those are the newest ones on this diagram. There are actually some more since then. And what happens with those is that although they're less likely to cause the unintended side effects, if I just gave them to a random person, they're not as likely to work as, for instance, Prozac. Does that make sense? Okay, so depending on the severity of what you're suffering with, if, for instance, you are suffering with debilitating depression and suicidal ideation, they might start you on Prozac, yes? Because you're like, you got some big crap you're working on and we got to deal with it. If, however, you're feeling like a shit sandwich but not a soggy one, right? They might start you on something way down here, right? And then just see if it works. And if it doesn't work, for instance, you can use something that's less selective and more likely to have side effects. Does that make sense to you guys? Okay, so let's just talk about your own brand of crazy, because we've got our own brand of crazy, and I've like experimented with all of these because I'm always trying to get my crazy to just work for me. Like, I accept the crazy. I just need you to work with me. I just need it to manifest in like over researching and being really good at my job and not, for instance, picking a zit until it bleeds, right? I don't need one of those. I need the one that actually works for me. Okay, so just think about this. Now, I am not trying to be your medical doctor at all. I am simply talking about how an educated person might make decisions about their own mental health. Okay, so first, let's acknowledge the thing that we've talked about before. If, for instance, you are dealing with depression or anxiety, does anybody ever measure your norepinephrine, dopamine, and serotonin levels? No. And why don't they? Because they can't. Yes. So what we all need to be aware of is the fact that if you go into a medical professional and decide to do something neuroactive to treat, for instance, depression or anxiety, you are engaging in an experiment. Yes? Aren't you? Yeah? You are engaging in an experiment. And there's nothing wrong with engaging in the experiment, but you should be as educated as you can be while you engage in the experiment, right? So what I do, and my doctors both find it entertaining and irritating, I'm going to say more entertaining, but is that I research all of the drugs that exist, and then I look at the dosages. And as far as dosage goes, by the way, if you take an SSRI, do you think there's any possibility of downregulation of your serotonin receptors? Yeah. So dosage. What would you think about dosage in the initial stages? As low as could possibly be effective, unless, of course, you were in a suicidal situation, and then they're going to make sure you don't kill yourself, right? But if we're talking about a person who's going in and just trying to figure out how to make their brain work a little better, as low as possible. And how about which ones you might want to try first? You want to try, it depends on where you are, right? If you can handle maybe it taking a few months for it to work, you could try one that's more selective. If you've got serious problems that need to be managed, they might try that one. It's good for you to know that. And then, why on earth would you not take notes? Why would you not record how you were feeling so that the next time you went in, you could report some actual data back to the doctor? Yes? You report, for instance, how you're sleeping. You report any changes in your sex drive. If you've gained 15 pounds, they need to know that, right? And then you guys engage in that process of experimentation together instead of just, most people don't do that, right? They just like throw it at you and then they ask you if you feel better. Well, I have an app on my phone that every single time I do some neurological intervention, I like enter 5 different categories of behavior per day. And then I take it back and I'm like, oh my God, I don't want any of this. And I'm like, well, if you don't want any of this, then I'm just going to tell you that what I would like to try next is this drug and this dose. And sometimes they say no, but sometimes they say yes. And then sometimes they say, maybe you're just this person. Maybe that's just who you are. I'm like, maybe you're right. Maybe this is just me. Okay, so those are SSRIs. I find SSRIs really interesting. They are usually the first tier of antidepressant and anti-anxiety medications. You are usually going to be offered an SSRI before you're offered an SD or SNRI. And sometimes, by the way, people take both of them at the same time. Some people take both Wellbutrin and an SSRI. Yeah? I have a little trouble with that because that's an experiment without any kind. You're like burying too many variables at the same time, people. How the hell do you know what's working? But, I mean, if you've got serious depression, then maybe you would consider that. Okay, so what about hallucinogens? So hallucinogens, including psilocybin, LSD, mescaline, peyote, all of those are based on the serotonin system as well. And what they do is they're not selective at all. What they do is they end up affecting just everything at the same time. So they end up causing sensory and motor activities. They depress your appetite. They have impacts on your sex drive. They can cause anxiety. They can cause obsession. They impact your mood. They are, however, usually not used as daily medications, right? They're not used as daily medications. So LSD and psilocybin are hallucinogens. Almost every hallucinogen that we have ever discovered or made is based on serotonin. Okay? Almost every one. So these, of course, you probably know mostly as illicit drugs, but do you also know that they are being used in clinical trials for treatment-resistant depression? They're still Schedule I in this country, which means it's really difficult to get research permission and research money to study them. But LSD and psilocybin have had some people, for instance, with bipolar disorder and with treatment-resistant depression. They've been used in clinical situations, and they've actually come out of treatment-resistant depression. So I'm just going to go ahead and tell you that. I'm sure you already know. But if you are actually curious and want good scientific peer-reviewed information about drugs, yes, and not Joe Blow's political page that wants you to vote against something that they hate, right? Okay. Where do you go? Where do you go to find good peer-reviewed information? Yeah, you go to PubMed. And or, do you guys know about this search? Not Google, but scholar.google.com. And there's a little search button that you can click that will only bring up peer-reviewed articles. Of course, they are harder to read, right? We know that. Because if it was real science, it wouldn't fit in a meme, right? But if you really, really want to know what's out there, then please be the person who can use your information about physiology and your intellect to like carefully assess the information. So I think it's interesting, this stuff, the hallucinogens and research on treatment-resistant depression. And then the other one that's really interesting is MDMA, which is ecstasy. MDMA is not like a typical hallucinogen. It does two things. MDMA, which is ecstasy, causes a massive release of serotonin and inhibits reuptake of serotonin. It does both of those. Okay. So historically, MDMA was originally developed as a therapy drug, and then it became a club drug in the 80s. Then it became Schedule 1, so it became illegal, right? And then, of course, when anything's Schedule 1, you can't do research on it. So there were decades in which we didn't do any research on it. And now, over the last 5 years, MDMA has been researched for PTSD, and it has been fantastically effective for PTSD. So here is the first clinical trial that they used it for PTSD, and there's now a second clinical trial, which is dealing with soldiers. The first clinical trial, and you guys definitely should read about this if you're interested, with MDMA is they found that, so with MDMA, one of the things that it does is because of this massive effect on your brain, this massive release of serotonin, it sort of removes your barriers to communication, and you can talk about things that you wouldn't normally talk about. You have this massive influx of trust in the situation, which is sometimes a barrier with people with PTSD, which they're changing. One of my students educated me and told me, we're actually trying to change it from PTSD to PTSR, post-traumatic stress response, because it's actually a natural response to those kinds of things. But I can't change that today. So assume that I'm going to say it. Okay. And also, when they did the research, it was research for PTSD. So we have these people, this group of people that suffered violent crime or a violent situation, and they had treatment-resistant PTSD, right? And they had massive symptoms from PTSD. And so the clinical trials that they put in order were, if I remember correctly, 4 months worth of treatment during the actual clinical trial. I think they probably went and stayed in treatment afterward. And every week they had a therapy session with a psychiatrist. You with me? Okay. And then once per month for 4 months, they had one of those sessions with MDMA. Okay. They had MDMA, they had a nurse, they had a psychiatrist, right? And they monitored all their vitals as they were going through the situation. So it was carefully controlled, and of course the MDMA was pure MDMA, no weird crap in it. And what they ended up with was amazing. After 4 months, they had about a 60% reduction in PTSD symptoms. And then 2 years later, they had still retained those changes, which is amazing for PTSD because it's really difficult to get any movement in PTSD at all. So that was the first round of clinical trials with MDMA. And then the second round of clinical trials, they were trying to get permission to do it with soldiers who had PTSD from soldier situations. And they finally got permission to do it. So that one's underway right now. So this one will be an interesting one to see. It will probably be legalized in some places in the United States within the next 5 years. This won't be one of them. Let's be serious. If you got some serious medical problems, you probably need to move. And it'll probably be legalized 15 years later in Utah than it is everywhere else. So that's MDMA, which is ecstasy. Go ahead.
Taking these drugs for a long time, or maybe one thing.
Oh.
Does it cause downregulation to neuroreceptors?
Definitely. So let's talk about ecstasy and how it's used as like a club drug, right? And how it has been used. Does ecstasy have any negative repercussions when you use it regularly, for instance, as a club drug, which is how a lot of people do? It absolutely does. First of all, it can cause serotonin. So when it's used as a club drug, have you ever heard of like Suicide Tuesday? Okay, so here's what happens with people who use MDMA, and I'm not talking about clinical usage now. I'm talking about illegal usage of MDMA. I don't think it's legal actually anywhere that I know of, but I might be wrong. It's not legal in the United States. So you take it, and then instead of taking it once, right, you take like multiple times over the course of a weekend, right? And so what it does, of course, it causes massive serotonin release and inhibits reuptake, which means that give yourself a few days and you are going to feel massive depletion of serotonin. Yes? Okay. So that's important. That's why they call it Suicide Tuesday, because if you did it on Saturday, by the time you get to Tuesday, you're going to have no serotonin whatsoever. And so you're going to freaking leave your spouse and everything in your life is going to suck. So when people do this, they say, just don't make any decisions on Tuesday, right? Pretty much Tuesday to then like the next Saturday, don't make any decisions. And then, of course, if you do that multiple Saturdays, right, you end up downregulating your serotonin receptor, and you can give yourself basically a chemically induced depression. Wow. Yeah. What is not true is what was published about 15 years ago about MDMA. They said that it caused holes in your brain. It doesn't cause holes in your brain. They retracted that study, but guess what happens? Once the study's out there, everybody just continues to repeat the information. What?
I think it's like a myth about all of them that they cause holes.
Yeah, it doesn't cause holes in your brain. What it actually can do over time, though, is end up causing you to decrease your serotonin receptors. If you continue to exhaust them, you are going to lose the ability to release massive amounts of serotonin. So you can have this sort of depression that's long-term. Now, that's part of the reason why in the clinical trials, they used it and then didn't use it for 3 weeks, and then used it and then didn't use it for 3 weeks. So repetitive use of MDMA is without a doubt negative for your brain. So I am not telling you a Hearts and Roses story about MDMA. I am saying that it probably has some decent clinical use that we will need to discover in the future. Go ahead.
I was just thinking, doesn't it make you extremely dehydrated?
Oh yeah, massively dehydrated.
ADH, and then you.
Yeah. But when it's under clinical conditions and you're being treated, they just make sure that your fluid levels and your electrolyte levels stay okay.
I think that's how deaths occur.
Yeah, there haven't been very many deaths. There's been only in the teens of deaths, but it's all been because of ion imbalances and dehydration. It hasn't been because of the brain activity. Go ahead.
How do LSD and psilocybin differ than ecstasy then in terms of like how if you're using it a lot? Like, does it downregulate still, or is it?
It does, but it doesn't cause massive release of serotonin. What it is a serotonin agonist and a serotonin facilitator. So, and you need really, really small quantities. LSD is like so massively effective, and it just makes the serotonin that's working work better and pretends like it's serotonin. And so it doesn't have the same downregulation possibilities as MDMA, because MDMA causes massive release of serotonin.
Okay.
Now, I am also, do not get me wrong, I'm not telling any of you guys that LSD is without its limitations either, but the physiology is what we're trying to talk about here. Okay, does that make sense? Okay, so all right, so there is in your textbook, I know how often you guys read your textbook, but there is a box in your textbook called Treating Depression that actually goes through the different tiers of depression treatment, which I think is kind of interesting. Go ahead.
One of the SSRIs, if I remember correctly, like one of the side effects is for teenagers and like younger adults is like killing themselves and like more suicidal thoughts. So why?
We do not know.
Okay.
That's so there's two things. First off, when you try to get off of SSRIs for anyone of any age group, you have to step off of it. Because when you're taking an SSRI, think about it, when you're taking an SSRI, you've artificially inflated the apparent amount of serotonin in your synapses, which can cause downregulation of your receptors. And if you go off cold turkey, what you can have is the worst depression you've ever had in your life. So going off SSRIs cold turkey for anyone increases the risk of suicide. But apparently the teen brain, the adolescent brain, all the way up to about age 25, responds differently to SSRIs than does the adult brain for reasons we don't understand. So there are some of these that are in the figure. Where the hell did I put the figure? There's some of these that are actually contraindicated for teen depression and teen anxiety, like that you just can't get a prescription for them for somebody who's that age. And there are other ways that they just monitor, but they don't do that in everyone. Sometimes they like provide the relief from depression that was their ticket into the world, and sometimes they actually end up with suicidal ideation. But of course, you need to know that, right? The teen needs to know it, and the parents need to know it. They need to know how to look for those kinds of things. So sometimes we really don't know. We don't know what's going on with the teen brain. The teen brain is like so complicated. There's so much synaptic pruning and repathwaying going on. It's really interesting. Okay, so the last of the biogenic amines is not one I know a lot about, but it might be important in the future, so I'm just going to put it down here. Oops, that's bad pen. It is histamine. Histamine, which of course you learned as a, God dang it. There we go. You learned it as a paracrine agent involved in like allergic reactions. Apparently, the hypothalamus uses histamine as one of its neurotransmitters. And I don't know if you guys know this, but the hypothalamus is kind of important. So I just put it in there because maybe we'll figure out something's going on with it. So hypothalamus neurotransmitter. Okay, So now we are ready to move to the next category. And the next category, wait, did I do them all? Yeah, I did serotonin. Okay. The next category are just straight amino acids. So straight amino acids, meaning that it's just the same as the amino acid that is part of a peptide. And there are 20 amino acids, but they're not all used as neurotransmitters. There are 4 big ones that are used as neurotransmitters. We've got 2 excitatory amino acids and 2 inhibitory amino acids. The 2 excitatory amino acids are glutamate and aspartate. And these apparently are more important than we initially thought that they were. Okay, so let me show you what they look like. So here's all 20 of your amino acids, but really it's just these 4. And again, it's exactly the same as it would be if it were part of a peptide, right? So they're just straight amino acids. They're not biogenic amines. Okay, glutamate and aspartate are almost always excitatory. And so glutamate is really important, and we're starting to study this one more because glutamate is important for CNS neuroplasticity. Does anybody want to hazard or give a shot as to what neuroplasticity is? What do you think that means? Go ahead.
The ability to form new pathways.
Exactly. Form new pathways and new synapses. Okay, so glutamate appears to be really important in neuroplasticity in both the hippocampus and in the cortex of the brain. Does anybody know what the hippocampus does?
Crack the hippocampus.
What does the hippocampus do? It's memory. Okay. All right, so this one is really, really important in neuroplasticity and the ability to form new synapses and reinforce pathways. So that sounds pretty damn important, right? This one is the one that is implicated in ADHD. So norepinephrine is also implicated in ADHD, but they think that glutamate is even more important. So this is implicated in ADHD. It's also implicated in Parkinson's disease. Parkinson's is mostly related to dopamine, but this is part of it as well. And then the drug PCP, which have you guys heard of PCP? I know Scott has. Scott's got a story for us about PCP. What?
I've heard horror stories.
Yeah, I've heard horror stories about it too, but even though I totally grew up in the hood, I never knew anybody who did PCP. And I probably have seen everybody do anything else. What?
It comes from, you can get it from plastic, right? It's like a chemical.
I don't know
They
where it
make
comes from.
PCP plastic, right?
They do?
Yeah, it's like really toxic for the environment.
PCB.
Right.
Oh, PCBs are different. PCP is, sometimes they used to call it angel dust.
Mhm.
Okay, so have you ever heard of this drug? And apparently Scott has had an unfortunate experience with someone on PCP, not him. Don't be judgment. So this is the drug, if you've ever heard of like a 150-pound guy that like, it takes like 9-10 dudes to bring him down, and they feel like they're 10 foot tall and bulletproof, and sometimes they like get violent and they're hallucinating all at the same time. PCP acts at glutamate receptors. So this drug, and people sometimes accidentally kill themselves. They'll decide that they can fly and just jump off a 15-story building. And I don't know that people do this very much, but Scott, tell us your little story about working on an ambulance and dealing with somebody with PCP, so they get the idea of what it was like.
Once we're going across for 4 years, we got a call to the Joseph Smith Memorial Building. The guy was upstairs. By the time we got to him, he's probably a 170-pound looking guy. He had, before we got there, the reason why we got called, is he had ripped a brass plaque off of a marble column, which is they're very strong. And he ran upstairs and had the ability to overturn a baby grand piano. And he got blindsided by like this massive Tongan who got him to the ground, and then 5 other cops got there, and we had to. So my job was to sit on his legs while they handcuffed his wrists and his ankles, banana shaped spit mask, and we carried him out in that harness.
Okay, handbag.
And he was thrashing the entire time, like moving all of these people that are trying to hold him down. And again, he's like 170, 180 pounds.
You got a Tongan, you got you, and
Yeah.
Yeah. So that's basically, I don't know that people do it anymore, but I'm probably too old to know what drugs people do anymore. Like, I don't know, and I don't care anymore. I'm like, yeah, whatever. Have you heard about sleep? Because it's really nice. Yeah, that's what Okay, so PCP acts at glutamate receptors. Ketamine, you guys have heard of ketamine, right? Ketamine was originally used as a horse tranquilizer. Apparently, it's used as a sedative during surgery, too. It's a glutamate antagonist, and so what it does is blocks glutamate's activity, that excitatory activity, and you can get conscious, right, sedation with ketamine. Go ahead.
There's a new study about ketamine's effects on depression.
Yes, I saw that too. Yeah, apparently ketamine can be used to relieve treatment-resistant depression. I did see that study, but I don't think that I read all of it. What do you know anything about it?
Not a whole lot, but it's been found to be like really effective. Like one half of it, like you're good for 4 months.
Really? Huh. And they're doing clinical trials with it?
I think so.
There's actually a few clinics here in Utah that use it for treatment right now.
Really? And how, do you know under what circumstances somebody would do this?
For treatment-resistant depression. So they'll go in, they do it like once a week and it's an IV. And then it allows them to work on things in the meantime.
Interesting. I'll have to look at that one. Go ahead.
So we've been making it as a nasal spray
Oh, yeah, because you work at a compounding pharmacy.
for depression, and they'll do like a lot. We'll do like a lot of sprays, for like 5 minutes, continuous sprays, and then they'll take like a couple days off, and then they'll do it again. But they'll have like so many treatments throughout the day, that one day, and then they'll have several days off. It's really interesting.
Interesting.
But there's like no long-term study on it.
No.
And to me, that's a little scary because it's like.
Yeah, it's always really scary, but like sometimes treatment-resistant depression is like deadly.
Yeah.
So yeah, they just do decide with these no long-term studies. So basically, don't jack with your neurochemistry if it's working okay. says me, who's like tried everything, tried to get mine to work. Finally, I'm just like, well, apparently I'm just like this weird person. You know, it's fine. Go ahead.
Oh, they're also using it, like, we'll make it into a lozenge for pain.
What?
They're using it for pain patients also, to try to get.
I did not know that either. Oh my goodness.
To help with, like, people are on massive amounts of, like, oxycontin and
Oh, interesting. I'm going to have to look that up.
kind of dosing them off of it a little bit.
Fascinating. Okay, aspartate. So glutamate and aspartate are the excitatory ones. This one is primarily like cerebrum, also hippocampus, but that's deep to the cerebrum. Aspartate is active in the spinal cord and the brainstem. And it has a lesser affinity for the same receptors as glutamate, but it's like more related to lower functionality. And glutamate is related to higher functionality, like neuroplasticity and brain function in the cerebral cortex. So the receptors for glutamate and aspartate are called Nmda receptors, and the only reason I'm going to tell you that is that as you get into pharmacology, you're going to end up seeing Nmda. I don't even want to tell you what it stands for because it's too long for me to remember. So Nmda receptors, for whatever reason, that's what those are called. Okay, now the inhibitory neurotransmitters are GABA and glycine, then inhibitory amino acid neurotransmitters. And this one's my favorite because it's your chill out neurotransmitter. I don't have enough of it, so I'm constantly chasing that one around because I got no chill whatsoever. Okay, so GABA is gamma aminobutyric acid, and it is nature's Valium. It is your chill out, everything's going to be fine neurotransmitter. It feels super great. It makes you like be able to weather pretty much anything. You can feel the effects of GABA after an orgasm. That after you take a sip of wine, you can feel it as well. Kind of lowers your blood pressure in the peripheral nervous system, but also relaxes your brain. The receptors for GABA are called GABAergic receptors. And the reason that this one is like worth talking about is because alcohol enhances GABA's action. So when you take a sip of wine, you get that relief and relaxation. It doesn't do it the same as Valium and clonazepam. We'll talk about those in just a second. However, at least in some people, One of the issues with alcohol is that alcohol in some people also activates the dopamine reinforcement pathway. So, of course, alcohol has the potential for addiction. Yes? In some people. Is it in everyone? No, it's not in everyone. But do you know, or whether you are one of the people who has a predisposition to activating the dopamine pathway with alcohol use? You don't know. I would love it if they would, again, come up with that test so that you could give it to your 14-year-old and let them know, hey, alcohol is really going to be a bad choice for you. Among all of the choices, alcohol is going to be a bad choice for you. So it actually activates this dopamine reinforcement pathway in at least some people. And there does, again, seem to be a genetic predisposition as to whether you are going to be one of those people that will activate the dopamine reinforcement pathway with alcohol usage. And we don't know a dependable way to predict whether you are going to be that person or not. So that's interesting. So alcohol enhances GABA's action. It's basically a facilitator of GABA. Go ahead.
So people are always buying GABA supplements at Whole Foods.
Yeah.
Is that not going to do anything because it's a CNS?
So I can't imagine that it would do anything.
Yeah.
The same thing, she told me, oh, did you ask about serotonin supplements?
We didn't get to it.
Okay, so apparently her compounding pharmacy also sells serotonin supplements, but it's water soluble. How the hell are you going to get it past the blood-brain barrier? And GABA is also water soluble.
Yeah.
So if it works, then I need to understand the transport mechanism that gets it into the brain.
Yeah, I feel like if that worked, it would be a bigger deal. Like it probably does nothing with vitamins.
As a placebo effect?
Just making a bunch of money.
I don't know. I can't imagine how it works. I don't know that it doesn't, but unless there's a transport mechanism to get GABA into the brain, and I would totally be taking it every day to chill the hell out, but I don't.
I mean, wouldn't more people be taking it, like, because of doctors' orders and stuff? But actually,
I don't think people are like listening to their doctors when they go to Whole Foods.
They don't believe in science so much.
Their doctors are like, so what would you do if you were dying? Which supplement would you take? I'm like,
Which crystal would you stick up your vagina if you were? Yes, I do have a friend who like sells that service, like deciding which crystals are right to stick up your vagina if you're feeling whatever. And I'm like, it doesn't go up there. What are you doing? You're gonna get what? I'm just like, whatever. My husband, when stuff like that happens, he just like puts his hand on my knee to try to get me to shut up in public situations. He's like, don't. Because I get all pissed off. Okay, all right, so the other one that I want to talk about, and you guys will have experienced this or will experience this, and this one is really important to talk about, is the category of drugs called the benzodiazepines, and they include Klonopin and Xanax and clonazepam, and there's like 5 more. Help me think of them. Lorazepam, anything that ends in a Pam. Yeah, all of those. What? Temazepam, all the Pams, right? These are the benzodiazepines. And benzodiazepines are a really interesting category of drugs, and they're very useful. However, they are also very, very risky, okay? And they prescribe them here in the United States in a very different way than they prescribe them in, for instance, Western Europe and Canada. So what these are is these guys enhance the activity of GABA. And so they are anti-anxiety drugs, yes. You can also use them as anti-seizure medications, okay. They also have a PNS muscle relaxation effect as well. So all of that sort of goes together, okay. You never ever want to take them in combination with alcohol because although they don't work the same way, you are adding the effects, right? And you can relax yourself to death by taking those two in combination. And people do it all the damn time, and people die from it too, okay. Go ahead.
This is probably like a lot of people take Valium.
Yeah, and benzos. I know more people who take Klonopin or clonazepam than take Valium anymore. I don't think Valium is Valium prescribed very much anymore. I wonder why. It's probably just we've come up with better options. So, so these are anti-anxiety medications. And how they're supposed to be used is as rescue medications. You are not supposed to take them regularly, but you will run into people all the time that take them every single night for sleep. Okay? They have a massive predisposition to downregulating receptors. It happens in about 2 weeks with regular usage. Okay? And when you try to get off of them, they can cause muscle spasms and seizures. They can even cause seizures that are so bad they will kill you. So these drugs are serious drugs that are supposed to be used as rescue medication. I have like an anxiety disorder. I always have clonazepam prescription, but I don't use them regularly because of the predisposition for downregulation. But also just like having the pills with me means that I feel like I'm more capable to manage a panic attack, right? Because I know they're there. Go ahead.
Is this similar to like the effects of a muscle relaxer?
It's a different thing. These have a secondary muscle relaxation effect, but only because they actually inhibit the nervous system that activates the muscle relaxation. So it's not the same effect. So the reason these are worth taking a minute to talk about is because they're supposed to be a rescue medication that you're not supposed to take very regularly, but people do take them really regularly. The problem is that when you try to get off of these rescue medications, if you do it cold turkey, you can have seizures and you can die. Interestingly, even here in Utah, guess which drug we have to keep you on if you were incarcerated and you went in addicted to it? Not opioids. They'll let you go through withdrawal with opioids because you probably won't die, although you'll feel like you need to, right? But with benzodiazepines, if you were on benzos going in, the state has to keep you on benzos because you will die if they take you off of benzos. So,
change the dose.
oh yeah, they try to downregulate to reduce the dose, but if you start having seizures, then it's very expensive and then you get sued. So, in addition, these are of course used for seizure disorders, including but not limited to epilepsy. And they suffer downregulation. If you're using them for seizure disorders, a lot of times you're taking them regularly because you must take them regularly, right? Okay, but you downregulate your receptors, right? And that means that over time, what happens is the same amount will not decrease your seizures. So you have to up the dosage, okay? Now, one of the things that's really important for us to talk about with this is that this is one of the two, well, there's more than two, but one of the two that we're going to talk about, relatively effective anti-seizure medication, and the other one is not legal here in Utah. What is the relatively effective anti-seizure medication, especially for childhood seizure disorders? THC, marijuana, cannabinoids. They are massively effective at decreasing seizures for reasons we don't understand yet. But here in Utah, of course, medical marijuana is still illegal. Next week, a week from today, there is a vote on it. I hope that you all vote, regardless of how you vote, because less than 20% of people under the age of 30 vote. And how do you think the oldsters are doing running the country? You liking this? Are we doing great? Yeah, well, then get out there and vote, okay? Regardless of whether you just agree with me and you're just going to contradict my vote. That's a reasonable reason to do it. That's the whole reason my mother-in-law votes, to make sure that mine doesn't count. She votes just to contradict what I do. But and last time my husband like took her to the wrong polling place. He's like, and then he took her to the right one. Go ahead.
So when you said that the prisons will then have to take them off those?
No, they try.
They try and like wean them over.
Yeah, a lot of times they just stay on them the whole time they're in
So if
prison.
you're doing
But they don't.
Go ahead.
They don't get out the alcohol.
No.
But then people can die from that, right?
Not very frequently. You'll die from going off of benzos pretty frequently. Yeah. Go ahead.
So if you're addicted to Valium, it's going to downregulate your receptors.
Yeah.
For GABA.
No, downregulate your GABA receptors. Yeah.
Your GABA receptors. Okay.
Yeah, it's going to downregulate your GABA receptors is what it's going to do. So this is an interesting one. And like I said, I checked in France. I couldn't find the information for Canada. But in France, you cannot get more than a 30-day supply of benzodiazepines for a 60-day period. So they're trying to reduce how much you take and how regularly you take. Of course, people are just going to cut them up, but it's going to decrease downregulation a bit anyway, to take less over that time. So that's Valium and clonazepam. There's another text box in your textbook about the role of GABAergic agents. It's kind of an interesting one. It talks about alcohol and it talks about benzodiazepines in there as well. Okay, so that's your benzodiazepines. By the way, it can take up to 2 years to upregulate your receptors from benzodiazepine usage. It takes a long time for you to have a normal response to benzos again. Go ahead.
So if you're taking it right away and just taking it occasionally when it was needed, then if you were to go off it, you wouldn't have the same side effects.
Yes, you would.
You would.
Yeah, even trying to go off of normal usage of benzodiazepines a lot of times causes muscle twitches and a bounce back anxiety, right? People have trouble getting off of benzos once you've been on them. It's difficult. It's not impossible, but sometimes it's a relatively long process, and they sort of need to know that it's going to be a long process to get off of those. So a lot of times people just stay on them for the rest of their lives. Go ahead.
Why is it so quick to downregulate and so slow down?
We don't know. And there's different categories of benzos, the different slow release and long release, and some of them are more likely to cause downregulation more quickly, and some of them are less likely, and a lot of times they'll switch you between those. Okay, glycine is this one, and glycine has a similar activity, but it's, again, active in the spinal cord and brainstem. Have you guys ever heard of strychnine? Strychnine is rat poison. Yeah. Strychnine kills you, or the rat, because it's an antagonist for glycine. And you just go into basically seizures because of spinal cord and brainstem activity. Okay, so now let's move on to purines. We're just going to do these briefly. So do you guys remember purines and pyrimidines from 1610? Tell me you do. No? Purines, the A in your AT base pair is a purine called adenosine. ATP is adenosine triphosphate. ADP is adenosine diphosphate. Does that sound familiar? Now, you are used to thinking those as thinking of those as either parts of nucleic acids or parts of energy molecules. But guess what? Your body already knows how to make them, so it makes them and releases them as neurotransmitters. ATP is used as a neurotransmitter. ADP is used as a neurotransmitter. And then our friend, adenosine, ATP, ADP, and adenosine. Adenosine is an inhibitory neurotransmitter, and our friend caffeine actually blocks the effect of adenosine, which is why it's sort of mentally excited for it. It blocks this inhibitory neurotransmitter called adenosine. Okay, and now we are to the neuropeptides. The neuropeptides are short chains of amino acids. How short? Usually between 5 and 40 amino acids put together. So let's look, just for comparison's sake. Here's an amino acid, yes? Here's a neuropeptide. So it's bigger, it's not huge. It's not like a quaternary protein, right? Like a big folded protein. So this is a neuropeptide. Because it's a little bigger, do you think it's faster or slower to diffuse across the synapse? Yeah, it diffuses a little more slowly across the synapse. It's not quite as fast as the rest of them. This is only one of them. This is beta endorphin. There's several. But the two, do you know the term endogenous? Do you know that term? Endogenous means I make it. So an endogenous opioid would be an opioid that I make. But I could also take an opioid that an opium poppy makes, right? But my endogenous ones are the ones that I make, okay? So the endogenous opioids, your neurotransmitters that are opioids, are endorphins. You've heard of those before, right? And enkephalins. And opioids are, of course, really important to talk about right now because I know that you know that this country is undergoing an opioid epidemic. So I want to talk about why you have opioids and then why you would take something that interacts with opioid receptors. Does that make sense? Okay, so the endogenous opioids include your naturally occurring endorphins and also enkephalins. So the evolutionary function of an endorphin is to get you through a situation without worrying about the pain or the risk that's involved in that situation. And then what happens whenever you release endorphins, guys, is that usually you reinforce that by activating the dopamine reward reinforcement pathway. So I want to think about this just evolutionarily. So let's say there's a saber-toothed tiger that took my baby, right? I don't even know if we actually existed at the same time, so I'm just making this crap up. Okay, I know dinosaurs and humans didn't exist at the same time, but let's just assume the age of mammals had both of them. Saber-toothed tiger took my baby, right? I need to go get my baby, even though I am probably going to get wrecked in the process. What I needed to have is an increased perception of my own capacity, a decreased fear response, yes, and a massively decreased pain response. Yes? That's what endorphins do for you. So what happens is I go get the baby away from the saber-tooth, assuming that I survive. What happens is I feel no pain during that process, And I actually release dopamine to reward that behavior, because the next time the saber-tooth gets my baby, what should I do? You should go get your damn baby from the saber-tooth tiger, and you should kill that damn tiger if at all possible, right? So this is a pain. It reduces pain perceptions. This is really important. Reduces pain perception. It increases your own perception of your own capacity, and it decreases basically sort of your inhibition, your fear response. So it's pretty pleasant, actually. So when people jump out of planes, they get this feeling, and it's reinforced by dopamine. Okay, Scott, and then you.
Are those released as well during exercise?
Oh yeah, I mean maybe for you, but not for me. I don't think. But yes, some people do. Mine is whatever the opposite chemical is that says, "Oh my God, why are you running in place? This is ridiculous." Go ahead.
Is it released during like childbirth, so you just like forget about, oh, that was terrible?
Yeah, you do release these
so
during.
I'll do it again.
Yeah. And then also all of your friends lie to you and just tell you it's amazing. Yeah. They're all bastards. Don't trust them. Okay. Sorry. She's totally like about to pop, and I'm like, this is gonna suck. Well, you didn't expect it was gonna be amazing, right?
No.
No. Okay. Okay. So I want to talk about this. So there are opioid receptors. Okay. The opioid receptors, there's many of them. They all have Greek letters. Delta, kappa, mu. Okay. Some are related to pain relief, and some are related to dependence. This mu1 receptor, when you activate that, it tends to cause dopamine reinforcement. So not surprisingly, what we are looking for clinical interventions is something that activates the opioid response, but not the dopamine response, right? Does that make sense? And we are having a little trouble figuring that out. So when opioids are released, dopamine is also released in the habit reinforcement portion of the brain. So basically what it does is activates this portion whenever you have the opioid release or opioid ingestion. So the clinical connection that's going to be important for you guys to understand is what we are doing when we treat pain with opioids is we're trying to treat this, but we also get all of the other things. We get the reward and reinforcement with the dopamine release. We also get the pleasure associated with dopamine, and we get the feeling of like I have an increased perception of my own capacity, right? And decreased inhibition, right? So it feels good for a lot of people to either make themselves release opioids or take opioids, right? That's not what we're going for. We're just going for the reduction in pain perception, right? But we get all of these unintended side effects. Why the hell do we use these at all? Well, because we don't have very many effective pain relief analgesics, especially for serious, massive pains. These are the most effective for serious, massive pain, but they come at a serious cost and a serious risk. So we have a whole bunch of opioids. They were originally derived from the opium poppy, but we also now have synthetic ones that are not derived from opium. So we've got morphine, heroin, codeine, OxyContin. There's all kinds. Percocet, some other stuff mixed in with it. And all of these have the potential for activating the dopamine reinforcement pathway. Do they activate it the same in all people? No, that's genetic variation. Do we know whether they are going to immediately activate it in you? No, we don't. Why is it that somebody can get addicted to opioids from, for instance, using opioids as prescribed for a dental procedure? Probably because of genetic variation. We don't really know. Interesting little historical footnote here. Morphine has been used for a long, long time, like since World War I, I think, for treating pain, maybe II. You guys know I suck at history. I think I, too. And then antibiotics were World War II, right? Morphine was World War I, antibiotics were World War II, I think. So morphine, but they found morphine to be very, very habit forming, and they noticed how much habit formation and addiction was happening in soldiers. And guess what they created to try to get people off of morphine? Heroin. Whoopsie daisy. And people are like, this is better. So all of those act at specific opioid receptors. Of course, anything that interacts at opioid receptors, or specific opioid receptors, are highly habit-forming and subject to downregulation. Now, the downregulation is a big deal because the downregulation occurs and you still have pain with the same level of opioid and you increase your opioid, right? And this can lead to an addiction pattern that can, of course, lead to moving from prescribed drugs to illegal drugs because, of course, you can't get the level of opioids that actually reduce your pain anymore. And do you know that most people actually go onto, for instance, heroin or street opioids from prescription opioids? Do you know that that's how the pathway usually works? It usually does work that way. It usually works that you can't get either any or enough of the prescribed medications and you start moving to something that's cheaper and easier access. And so you start moving to street medications. And we're going to talk about opioid addiction treatments next time, and then we'll talk about using whether cannabinoids like THC are a reasonable approach to pain regulation. And then you guys I'll give you some resources to read, and you can decide what you want, and you will vote next week, right?
Yes.
Yes, you will, even if you're just like, she's crazy. I'm going to vote against her. That's fine.
We have a quiz next week.
No, you have a quiz next time.
On top.
Mm-hmm.
In class. So where does
In class.
Adderall fall in? Would that be in like
Hold on just a second. Let me save this.